Hello, everyone, and welcome to the Radiology Cardiothoracic Imaging podcast. My name is Sonia Barra, and I'm the editor-in-chief of the journal Radiology Cardiothoracic Imaging. The host of our podcast is Praveen Ranganath from Dallas, Texas.
Hey, Dr. Ibarra. Hello, everyone.
Hi, Praveen. In this series of podcasts, we will break down recent articles and trending topics from the journal through conversations with the authors, the editors, and experts in the field. For all of you out there interested in cardiothoracic imaging, subscribe and listen to the podcast to keep up to date with recent developments in cardiothoracic imaging.
RSNA is now accepting abstract submissions for RSNA 2021. Submit your abstract and deliver fresh insights about important topics while you shape educational programming at the annual meeting. To get more information and share your work, go to rsna.org/abstracts. Submissions are due no later than 12 noon Central Time on Wednesday, May 5th. Hello again, listeners, and welcome back to the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath. On today's episode, we will be cracking into a recently published review in the journal. The review is titled Practical Imaging Interpretation in Patients Suspected of Having Idiopathic Pulmonary Fibrosis, Official Recommendations from the Radiology Working Group of the Pulmonary Fibrosis Foundation. This paper comes to us from our colleagues across the United States, from Kentucky to New York, from Chicago to Colorado. The first author of the review is Dr. Stephen Hobbs, and the senior author is Dr. David Lynch. As our listeners know, imaging in ILD can be very challenging. In an effort to make radiological diagnosis of ILD more practical, the Pulmonary Fibrosis Foundation created a radiology working group. This working group acted to create an imaging guide for ILD born from recent evidence-based recommendations. Our featured paper summarizes the working group's efforts and acts as a one-stop shop for everything related to ILD imaging interpretation. This review is jam-packed with information about all of the following: imaging acquisition, clear definitions and figures of specific imaging findings, an overview of UIP diagnostic categories, examples of non-UIP alternative diagnoses, potential confounding imaging features, an example CT reporting template, and advice for imagers on a multidisciplinary approach to ILD management. On this episode, I have the privilege of speaking with the lead author of our featured publication, Dr. Stephen Hobbs. Let's jump into my conversation with Dr. Hobbs now. Hello, listeners, and welcome back. I am joined by the lead author of our featured publication, Dr. Stephen Hobbs. Dr. Hobbs, how are you doing?
I'm doing well. Thank you for having me.
Of course, thank you for coming on to the podcast. As a reminder to our listeners, the title of your publication in the journal featured on today's episode is Practical Imaging Interpretation in Patients Suspected of Having Idiopathic Pulmonary Fibrosis, Official Recommendations from the Radiology Working Group of the Pulmonary Fibrosis Foundation. So, Stephen, before we dive into the publication, let's learn a little bit about you. Tell us more about who you are, where you work, and what your academic interests are.
Yeah, sure. So my name is Stephen Hobbs. I am a chest radiologist at the University of Kentucky, associate professor there of radiology and medicine. And then in addition to chest radiology, I have a secondary interest in informatics. So I'm board certified in clinical informatics as well. And so I have roles both on the chest radiology side of things, but then the IT side of things. Basically, when PACS breaks, people call me and complain, that sort of thing.
Oh boy, I'm definitely guilty of sending multiple calls to you or your equivalents at my institution. So thank you.
Indeed, most people are on a daily basis.
Excellent.
So I'm at the University of Kentucky, and I've been there actually, since I became an attending, and I've been in academics the entire time. I did my fellowship at the National Jewish Hospital in the University of Colorado out in Colorado. Kind of specializing in diffuse lung disease, especially there. And that's really one of my primary areas of interest on chest imaging.
Excellent. And that kind of dovetails nicely into the publication itself. So, the review that's published in the journal summarizes the recommendations from the radiology working group that was formed by the Pulmonary Fibrosis Foundation. So, for background for our listeners, what exactly is the Pulmonary Fibrosis Foundation, and why was there a decision made to form a radiology working group?
Yeah, so the Pulmonary Fibrosis Foundation is a group of a lot of different types of people who study or evaluate or take care of patients or are patients who have pulmonary fibrosis. And so it's really an attempt to gather a large group of multidisciplinary areas and bring them together to do a more effective job studying pulmonary fibrosis, but also being very practical in how you take care of those types of patients. So there's a lot of effort from the Pulmonary Fibrosis Foundation to uh, provide resources, not just to other doctors and people taking care of these types of patients, but also to families and to patients themselves. And so if you evaluate the Pulmonary Fibrosis Foundation, they have a lot of different um, groups that kind of address those different areas.
Got it. Okay. Um, then, before getting into the recommendations that came out of that working group itself, do these recommendations build on anything previous in terms of either guidelines or consensus documents?
Yeah, so both the Fleischmann Society and the American Thoracic Society and the other international equivalent societies um, have guideline statements on how to evaluate these types of patients. And so this document builds on what they've done and attempts to be very practical and provide a very cohesive and comprehensive look, essentially a one-stop shop for somebody reading this document would come away with basically all the knowledge that they would need to hopefully properly interpret, evaluate, and report these types of cases.
Spectacular. Okay, so why don't we go ahead and begin talking about those recommendations themselves? The review that you've published has a nice summary starting off with in terms of imaging acquisition techniques, obviously focused around CT. A lot of us imagers are familiar with the inspiratory, expiratory, and prone imaging techniques, in addition to the thin slice, very edge enhanced, kind of sharp kernel reconstructions that we use in interstitial lung disease imaging. Are there any new or maybe potentially surprising acquisition techniques that are brought about by these new recommendations?
So I don't think that there's anything specifically new, but I think as you look across practice areas, there's still a surprisingly large amount of variability in what people do in their own practices for a so-called HRCT when you're evaluating these types of lung diseases. So I don't think we're really changing what those recommendations are. You know, the American College of Radiology has position papers on how to do HRCT, for example, and those sorts of things we try to incorporate into these guidelines. But I think we're really trying to make sure that people have an opportunity to look at the protocols that they're using at their institution and really update those. For example, you know, we still find some facilities that do the thin section 1 millimeter or less cuts that you expect for an inspiratory portion of the HRCT in a non-contiguous fashion. So some of them still have, you know, 1 centimeter or 2 centimeters even between those slices. And there's really no need for that with modern scanners. That might as well be contiguous and get you more information when you're evaluating these types of patients. And I think the other thing that can be looked at is the actual so-called high resolution kernel that is used in these reconstructions. And I think traditionally, a lot of facilities use a very strong edge enhancing kernel that gives a lot of additional noise. And that's probably more than is needed in a lot. So we can include in this specific recommendations or at least ballparks that people would use for different vendor scanners. So if you're a Siemens shop or a GE shop or a Philips shop, we've given some examples in this of the type of reconstruction kernel that you might want to use. And I think if people looked back at what they are using, it's probably a bit softer than a lot of facilities are using.
Excellent. And how about at your institution in Kentucky? Are you using an example of something I've been interested in is expiratory imaging and doing every 10 centimeters or so imaging, or you're reconstructing the entire chest, in addition to the other stuff we mentioned with regards to thin slices as well as reconstruction filters.
So we do not do a contiguous portion of the exam for those specific portions. I think for the most part, that's a way to reduce radiation in these cases. And depending on patient context and patient age, radiation dose may not be, that strong a consideration. But to the extent that we can reduce it, we generally should. So for those specific sequences, I think doing contiguous imaging is probably not necessary in a lot of cases, and you can do non-contiguous imaging and reduce dose in those pretty effectively and still get the same information that you need. Is there air trapping? Yes or no? Is there persistent reticular abnormality or interstitial lung abnormality on prone imaging, or does it all go away and it's all atelectasis? And you can answer those questions a lot of times without contiguous imaging.
Excellent. Okay. And we're kind of alluding to some of the interpretive portion of the exam now. So let's talk about that. Arguably, the fundamental reason why we do the initial diagnostic imaging for these patients with suspected interstitial lung diseases is to identify the so-called UIP pattern that can indicate a variety of different lung diseases, but really the most worrisome of which is idiopathic pulmonary fibrosis. So talk to us about why it's so important to identify this UIP pattern on CTs.
So this work for us has built on the same work that was done by the American Thoracic Society and the Fleischner Society guidelines. And so they outline a lot of the recent research in this area, which is basically correlating HRCT findings with pathology. And what we found is that with certain features identified on HRCT, that correlates with a very high degree of probability what we would see on pathology. And because those things correlate, we can avoid having to get pathology in those cases. So that makes it really important for this clinical population in particular, because it prevents them from having to potentially undergo a pretty invasive procedure, lung biopsy, open lung biopsy, specifically taking, multiple sections of lung out from multiple lobes in a patient whose lung is abnormal to begin with is not a benign procedure. And if you do enough of them, you will see bad outcomes that are unavoidable. And so despite every precaution that you take, some patients will have exacerbations of their lung disease. They'll have profound pulmonary hemorrhage after the fact, or they'll develop infections that could even claim their life. So if we can avoid that type of invasive procedure, we like to try to do so. But that being said, we have to make sure that we're matching those HRCT findings with what we believe we would see on pathology.
Excellent. Okay. Many of us have encountered real diagnostic dilemmas when it comes to debating between a UIP-CT pattern versus something else. So can you help us discuss a bit of those dilemmas that are often encountered, kind of focusing on the confounding imaging features that you mentioned in the review, maybe to help us imagers out there better differentiate a UIP-CT pattern or ILD pattern in general from other diagnoses?
Like I said, part of what we've done here is really kind of coalesce the recommendations from the American Thoracic Society and the Fleischner Society. So we're not redefining those categories. This isn't yet one more, category system that you have to memorize or figure out how it's going to report into or anything like that. We're not doing that type of thing. I think what we're trying to do here is kind of be very clear about what these definitions mean and what these terms mean to kind of get everybody on the exact same page. And so I think if you start from that kind of standard definition of terminology, which we include in this review to make sure that you're using those appropriate terms correctly, it really guides you very clearly to which category you should be in. So we want to make sure that the people that are reporting these types of Cs are using the word reticular correctly, are using the word ground glass opacity correctly, are using cysts versus honeycomb cysts correctly. And hopefully what we've done is provide examples of these different things so that you can see exactly what these terms mean that are, also explained in other works like the Fleischner Society Guide Glossary of Terms, for example, but really kind of providing that in a single resource for people to look at and read and understand. So if you take all those terms and definitions and fit them into the pre-existing guidelines for categorizing these types of patients, it leads you to one of those essentially 4 diagnostic categories. And I think in cases that are very clear cut, then it's very easy to figure out which one of those to get put into. But patients aren't always nice and clean, right? So they frequently have these confounding imaging features like we described, where they have pulmonary fibrosis, but they might also be smokers, right? So how do I reliably tell the difference between honeycomb cyst formation and paraseptal lymphedema? Well, in a lot of cases, it's not that hard, right? You can tell by the amount of additional distortion, by how thick-walled these things are, by the location in the lung, the presence of additional emphysema, and those sorts of things. But in borderline cases, which happen probably more frequently than we like to admit sometimes, we're not very good necessarily about distinguishing these types of things. And actually, if you look at previous work from a variety of other people, our internal agreement, between radiologists for is this emphysema or cysts or honeycomb cyst is not that great, right? It's kind of at the borderline acceptability of what we would consider viable, differentiation, those so-called kappa values and everything. So we try to elucidate and give some guidelines to help people with those distinctions, help people separate out traction bronchiectasis versus bronchiolectasis versus honeycomb cyst formation. I see a little bit of a peripheral type of cystic abnormality. It abuts the subpleural lung in the extreme lung periphery. Is that really a honeycomb cyst? It's not stacking. What do I do? Is that traction bronchiolectasis in the very distal airway, or is that really early honeycomb cyst formation? Because that's an important thing to differentiate, because it might change what category you put something into. Those are all those so-called confounding imaging features that can be, difficult to tweeze out sometimes. I think the other thing that makes these cases difficult sometimes to interpret is understanding the clinical context of what's happening with the patient at the time you're imaging. And that can be difficult for radiologists on a couple of fronts. One, we're generally not direct patient caregivers, so it makes it hard for us to understand some of that clinical context, or we might not even have access to it. It can be hard for us to find the patient notes, or we're not, may not have a multidisciplinary conference set up to discuss these patients one-on-one, or as part of a multidisciplinary group with other pulmonologists and rheumatologists and that sort of thing. But especially with patients whose clinical condition is changing or changing rapidly, understanding that context can really be key to figuring out how you would categorize one of these types of patients. For example, if the CT looks like classic UIP, but there's too much ground glass abnormality, by definition, you would have to categorize that as inconsistent, or suggest an alternative diagnosis of UIP, right?
Right.
But if you understand the clinical context of that patient was suffering from a known pneumonia on top of their, known pulmonary fibrosis, then you might be able to tweeze out the fact that, their underlying pulmonary fibrosis is probably UIP and still may be IPF, despite the fact that the imaging is at this time incongruent with that. Because I now know that there's a superimposed process because there's multiple things going on in the lung at the same time. And I think those sorts of issues can be complex to work through. So it can take a real team approach to doing that sort of thing. And that's one of the reasons why multidisciplinary discussion and is one of the most important things for evaluating these patients.
Yeah, that's excellent. I think it's a great justification for why we need to be extremely nuanced in our approach to these CTs when, yeah, sure, there's 4 very nice buckets that we can lump a patient into in terms of a UIP pattern or not. It might not be that straightforward with the confounding imaging factors as well as clinical presentation that you've mentioned. With regards to those 4 factors, From what I understand, they're born from two major guidelines documents. We've already kind of been talking about the 2018 Fleischner Society guideline documents, as well as the 2018 Multi-Society Clinical Practice Guidelines. Is there any major difference between these two in terms of how they describe, say, reticulations and honeycombing, if I'm to be a true purist with regards to how to approach the definition of these findings on CT?
Yeah. So I think that's one of the things that people get confused about. Oh, do I need to use the Fleischner Society guidelines or the American Thoracic Society guidelines as a radiologist? And one of the approaches that we've taken in this paper is to try to be very, very practical. So from a practical standpoint, there is no meaningful difference between these from an imaging standpoint, right? There are some very subtle nuances in the terminology that they use. But in an individual case, if you classify it as typical UIP by Fleischner guidelines, you will do the same thing for, the American Thoracic Society guideline. So from an imaging standpoint, from a radiologist standpoint, from a reporting standpoint for these cases, you're essentially doing the same thing. So if you're looking at one chart, you should feel good about the fact that, you would classify it similarly if you're looking at the, other chart from the other paper as well.
Gotcha. And just as a brief review, because some of our audience is not in a tertiary academic center that gets a tremendous amount of referrals for IPF or a UIP pattern on CT, can we walk through the clinical implication for each of those four categories, just briefly, so that we understand what the context and ultimate impact will be for those patients?
Sure. So there's really two major buckets for these patients. So there's four overall imaging categories, and those would be typical UIP, so-called probable UIP, indeterminate for UIP, and then CT features that suggest an alternative diagnosis. Basically, yes, there's pulmonary fibrosis here, probably, but it looks like some other disease process. And so you've got those kind of general four imaging buckets that these patients get put into after evaluating their HRCT. From a radiologist standpoint, the typical UIP pattern, that peripheral predominant, lower lung predominant reticulation, honeycomb cyst formation pattern puts you into that typical UIP bucket, which in the appropriate clinical context allows you to avoid doing biopsy in a large number of these patients. Now, one of the differences between the American Thoracic Society guidelines and the Fleischner Society guidelines is a slight difference in how to handle probable UIP patients. So for the Fleischner Society guidelines, they would suggest that similar to typical UIP, if you have a probable UIP pattern, again, in the right clinical context, you probably don't need to biopsy those patients either, because the pretest probability that that would turn out to be a UIP pattern if you did biopsy them and got the actual histology back is still high enough that it probably doesn't justify the risk of biopsy in a majority of those patients. But by the time you get down to the indeterminate for UIP, that's no longer the case. So the majority of those cases need to be biopsied. And the majority of, well, not the majority, at least some of the CT features that suggest an alternative diagnosis cases should also be biopsied, unless it's a pretty clear-cut example of a case that has a clear clinical context that's consistent with another disease, or the imaging features are just classic for that other disease, in which case it would be a moot point to biopsy. So I think the thing to remember from a clinical management standpoint is that as long as the clinical features are typical and consistent for both typical UIP pattern and probable UIP pattern, you probably don't need to biopsy a large number of those patients. If you're biopsying a large number of those patients still, you probably need to double check what you're doing. But you're still going to end up biopsying a large number of the indeterminate UIP patients for those where truly knowing the underlying diagnosis would actually matter. And I think that's something that we have to ask ourselves all the time, because there is, as we talked about before, risk to biopsying these types of patients. So we have to make sure that we're not doing it for academic reasons, right? We want to have those biopsy results guide what treatment options are available for that patient. And if it's not changing that management, we need to double check, is that really worth the patient going through?
With regards to that exact point, we had mentioned earlier multidisciplinary approaches to these patients. How do you guys typically approach patients with these indeterminate UIP patterns on CT at your institution? Is there a significant discussion? Is there a QI process for how frequently these patients undergo biopsy, et cetera?
Yeah. So we do have a multidisciplinary conference for diffuse lung disease cases like this at my institution. And I think if you are at a facility that has that, then great. That's really the way you want to be handling, evaluating these kind of complex patients. If you're not at a facility that has that type of opportunity, then I think it'd be great if you start to think about what that might look like. Now, these diseases are fairly rare in the grand scheme of things, right? Compared to the cancer cases, compared to the stroke cases and those sorts of things that clearly affect a larger number of people across the world. These cases are relatively rare. So maybe you don't have enough of these types of cases to have a multidisciplinary discussion once a week or something like that. But if you have a group of like-minded clinicians and radiologists, even if it's just one pulmonologist and one radiologist who can have a conversation about these types of patients, then I think that's a step in the right direction. And understanding how to structure that, the types of questions that you'd want to ask at those conferences comes with experience. And it's those types of things that the Pulmonary Fibrosis Foundation can help with. Coordinating those types of cares. If you're interested in figuring out how to set those types of things up, or having experts in these areas from a pulmonologist or a rheumatologist or a radiologist standpoint help with that, or keying into other academic centers that do this type of thing. Having that type of referral option or education option, I think, is a great thing. But it does require work up front to get that type of activity started. And I think we all are overworked to begin with. So that can be a pretty big challenge sometimes.
Yeah, but I think you've provided great justification for why it is appropriate to at least continue in institutions that have them, or start in institutions that don't, a multidisciplinary approach like this. Yeah, that's fantastic.
And I think, one of the things to remember is I would not suggest that it's necessary to speak about every single one of these patients that comes across the door, right? So if they're classic, right? If the clinical history clearly fits with a diagnosis of IPF and the imaging clearly fits with a diagnosis of UIP, there's probably not much added benefit to discussing that type of patient in a multidisciplinary discussion, right? Especially given how time crunched everybody is this time of day. But if there are confusing factors, if there's potential, occupational exposures or potential pharmaceutical exposures, drug toxicity, those types of things that may or may not play an impact on what the final diagnosis is, I think it's those types of confounding factors that can make multidisciplinary discussion important. Especially for those with connective tissue disease, engagement with a rheumatologist can be really important. People who treat a lot of diffuse lung disease become very, very familiar with the myriad different serologies that get run in these patients looking for evidence of those connective tissue diseases. And it's so many that it's very difficult to just keep up with. And they come out with new ones fairly frequently and new diseases that they've decided to rename. And I think having rheumatology at the table can be very helpful in describing these patients. So we have a multidisciplinary group that involves not just radiology, but pulmonology and pathology, a pathologist with a specific interest in lung diseases, which is hard to come by themselves sometimes. A lot of facilities would need to send those types of studies out to referral centers to have really subspecialty level pathology expertise, which can play a fairly important role just for diagnosis of these patients as well. We also have rheumatology as well, and of course residents and fellows, those sorts of things. Those trainees are involved as well, because we want to train the next generation of people to understand this and keep the torch going. Our conferences don't tend to involve thoracic surgeons unless we're specifically talking about biopsy. And I think involving thoracic surgeons in those conversations can be very important and can really help with patient management, which is a little bit counterintuitive to some, but it's because they're the ones that are going to actually do the open lung biopsy. And we found that, at least in some cases, patients will get referred for an open lung biopsy appropriately. It was a biopsy that needed to be done, but a conversation wasn't had with the thoracic surgeon ahead of time. And so the wrong areas of the lung were actually biopsied, right? Which, again, you just think, oh, I'll take a chunk of the right middle lobe, I'll take a chunk of the right lower and the right upper, and I'm all good, right? But if you have a clear-cut area of really severe end-stage fibrosis and you biopsy that, say down in the right lower lobe, that's probably not going to help you nearly as much as some other areas of the lung that are less involved and can give you a more accurate idea of the actual pathological process that the lung is undergoing. Because end-stage fibrosis, a lot of times on pathology, and I'm no pathologist, so don't make that mistake, but can look very similar despite whatever the underlying etiology was. So if you get an area of lung that's slightly less involved, then sometimes that can provide you clues that, oh, this has some evidence that would suggest it's actually HP, right? Instead of it being actual UIP or IPF, or there's evidence here of connective tissue disease that I wouldn't have seen if I had biopsied another area. I've also seen cases where there was really abnormal pleural disease on one side versus the other. And so when they biopsied it, they essentially got that pleural rind and lung back, and that really wasn't characteristic of the rest of the lung. And it turns out that that patient had trauma and hemorrhage into the pleural space. That didn't have anything really to do with their diffuse lung disease, but that's what the biopsy comes back as, rather than focusing on the actual lung parenchyma that we're more interested in. So like I said, we don't have thoracic surgeons involved with our conference as a matter of routine, but I do think it's very useful to have specific discussions with them if you're sending a patient for open lung biopsy about exactly why you're doing it and what you need from that biopsy.
Yeah, I think that point is so important because in training, it's not often emphasized that the imaging will inform not only who can benefit from a open lung biopsy, but also where you can obtain the best results in terms of what your histopathology is going to end up being. Excellent points. Thank you very much for that. At the end of your review, you actually offer a nice standardized reporting template for interstitial lung disease CTs. Is the goal here similar to that of other reporting and database systems like LIRADS and BIRADS or CADRADS?
So I would say overall, no. So I think other people have published, an option for essentially having an ILD RADS category, I think out of the ACR. I think it was Brent Little's group had done that as well. I think what we're really trying to get at here is offering people a way to feel confident that they're addressing all the things that need to be addressed in reporting these types of cases. So I think diffuse lung disease, ILD, HRCT, if it's not something you do on a routine basis, you get a bit overwhelmed very quickly with that. We certainly see that in trainees, and we certainly see that in people out in private practice who are extremely good radiologists, but these are relatively rare things that they come across, right? And they're not exactly sure, okay, I don't normally talk about this on a routine CT of the chest. Is that something I need to talk about here? Am I using the right language? Am I hitting all the key points that a pulmonologist needs to know to guide therapy? So I think the attempt here is to give people an option of, a more standardized type report that definitely addresses all those key features. So again, if you, were to fill out that standardized report, it should dump it into one of those 4 buckets, right? You should be able to figure out exactly which one went into. If you use the terminology the way we describe with those definitions, then you're using that terminology correct. Reticular abnormality is the same thing for you as it is for me, so on and so forth. So I don't think that we necessarily need to have another, lung rads type, definition or categorization. It's kind of like that as far as the categories to begin with, but especially anything that ends up in that so-called fourth bucket, the suggests an alternative diagnosis. There's 300 plus interstitial lung diseases. So that's a really big bucket to have as a single category there. So you should be saying in your report, not just, oh, here's the category that it's in, that it suggests an alternative diagnosis. You should say what alternative diagnosis it suggests. And that's, that can be hard sometimes. It's interstitial lung disease, and that's how it.
Oh, yeah.
Yeah.
I must admit the macro that I had tried to put together myself previously had paled in comparison. So full disclosure, I have stolen exactly what you've written in there as my current macro. So it's been what I've been using thus far for my ILD-CTs.
And so we put one that's absolutely. So we put one that's kind of a very comprehensive one. So if somebody wanted to start from scratch and didn't want to build anything, then they could feel confident that that would be it. Hopefully there's enough, pick list type things in it that it doesn't take that long to get through. Or we also have a focused template, recognizing that some people probably have a lot of structure that they already want to use. Some places use a lot of structured reporting already, other places not so much. But if you wanted to just have a much smaller kind of condensed template, you could steal, the parts of that you wanted to essentially without having to, redo a whole lot of the rest of your template or anything like that. So I think the major goal and focus with that is to give people really confident that if they include all these elements, they've produced a high quality report that addresses the information that a referring clinician and a patient need to know.
Excellent. Stephen, I think this discussion has been fantastic. Thanks so much for coming on. Any final thoughts before we conclude?
No, I appreciate your time. This stuff is hard. So HRCT and ILD in general can be quite daunting. So don't be discouraged. Hopefully you can read this article and see all the pictures that we've included. It's very image rich, hopefully, and you can come away with a good idea of how to report these cases and feel a bit more confident that you did than you did necessarily before you started reading it. So I appreciate your time. Thank you.
Of course. Thank you, Stephen. And to our listeners out there, definitely get your hands on a copy of this. Dr. Hobbs is being very modest. The images are fantastic, specifically with regards to delineating those very subtle findings. Thanks again, Stephen, for coming on and sharing your expertise and time. We really appreciate it. And to our listeners out there, thank you guys for tuning in. Once again, my name is Praveen Ranganath. I'm the host of the Radiology Cardiothoracic Imaging Podcast. If you do like what you hear from us on the podcast, please rate, review, and subscribe to us. Thank you very much, and we will see you next time.